What's up, guys? Welcome to Nurse Podcast with your host, Matt Shawtrick, and myself, Peter Findera. This nursing podcast where we tackle current health news and hot nursing topics, one conversation at a time. Welcome to have you guys here. We're going to have a good time today. We have a special guest on today. But don't forget, check us out on YouTube. Check us out on Spotify, Instagram. Follow us everywhere. Give us the like. Give us a comment. We're also starting up a new Patreon, so coming to you guys soon. How's it going, Matt?
Good, man. I'm just kind of really admiring your hair because you don't have headphones on. So if anything, please, guys, give 5 stars for PD and his beautiful hair. But today we have a special guest on, and I'd like to welcome Tori Meskin. She is a professional nurse of 70 years. She is actually a podcast host of the Nurse Tori Cellfie podcast, amateur wifey, workout enthusiast, healthcare blogger, and now she is training for a family nurse practitioner. If you want to follow her, IG handle is @nurse.tori, and her podcast is @Cellfie_podcast, and that's CELLFIE.
We love medical puns here.
Tori, how you doing?
I'm good. Thanks for the intro. Thank you for having me, you guys.
So, Tori, did you start off as a nurse, or did you have a career prior to doing nursing?
I was a nurse right off the bat. I went to University of Arizona, bear down. Yay for all my Wildcats out there. I knew I wanted to be a nurse right away. It was definitely always my goal. And I talk about this a lot. It was not an easy process for me. I was the person that literally could not get in. So I finally got in after about 3.5 times. And then it took me about 8 months to land my job. I've been a nurse now for 7, 8 years. And we were actually on hiring freezes back when I was getting hired. So I landed my first job in a level 4 NICU at a children's hospital in Southern California. And I worked there I've been there off and on for about 7 years, but there's been a lot of things in between. But yeah, I've been primarily NICU most of my career, and I loved the micro-preemie world. There's a lot of specialty things that I feel very fortunate. I worked at the first hospital where the quote-unquote small baby unit was created and fashioned, and the idea and the theories behind it were established by, her name is Mindy Morris. She's a nurse practitioner, and Dr. Solomon. They crafted a specialty, basically kind of growth program and or care plan for the micro-preemies. So I worked at the hospital where that started. And then I also work surgical, pre-op, post-op. We do pretty much anything under the sun for any baby born and up to a year. So a lot of our babies are with us up to a year. Beyond that, they usually go to the PICU or to the floors. So I started there, and then I did a bit of travel nursing in the Southern California area as well. And then now I'm actually critical care float pool. So I work CVICU, PICU, oncology, NICU, and then sometimes the floors when they need me there. So, yeah.
Very well-rounded. I'm very actually curious about the whole NICU life because I have never had anybody tell me much about it. And I really don't know a lot of nurses that work in a NICU. So can you kind of describe your life in a way and just kind of tell us maybe a slight tidbit about your shift?
Yeah. So it kind of starts at the foundation of what kind of NICU you work in. So there's 4 levels of NICU, one being more of a nursery all the way up to level 4, which is your children's hospital, university hospitals, ECMO centers, consult centers. So most of the NICUs I've worked in have been level 3 or level 4, where we do surgeries, micro-preemies, a lot of high-risk pregnancies and things like that. So your day comes on pretty much like any. We get 1, 2, or 3 patients a shift, just depending on the acuity. And we do work with babies, as small as 350 grams. I would say the level of care or the nursing skills take time. I would say it took me about 3 years to really feel comfortable, like somewhat comfortable. And even now, babies are very resilient, but they're also very reactive. So, if you're taking off a CPAP mask, just anticipate a bradycardia and a DSAT right away. That's just how you just learn, how to work, you learn diligently. You learn that you're very close with your RTs. When you're working with a 350 gram person and your ET tube is millimeters, you're not doing anything without them. So I feel very fortunate to have worked in places that have been, very supportive of sort of like, I don't know, the whole team, meaning nursing, RT, doctors, and I feel like we're getting very cutting edge with the NICU population. We've learned a lot about neonates and babies and growth over the past, I'd say, like 30 years. So many things have changed. Even me as a nurse, I've been a nurse for 8 years, and so many things that we do now are very different than we were doing even a couple years ago. So it's a very progressive unit. We're learning always. I don't feel like there's a day I ever come on and I'm not learning something. And it's also a different unit in the sense of we are often with our patients for months. And so I would say a big different aspect for us is really our relationships with the parents, because obviously, babies can't verbalize things. They can tell you things, with their vital signs. They can tell you things with how they react to things. There's a lot of things they can tell you, but from a verbal aspect, the way we really do that is with parents or the caretakers, the foster parents, or whoever you're working with. So we develop those relationships really strongly, which I really love and I value. I mean, I still have some parents that I talk to now, and my oldest associate, she's turning 7 this year, which is crazy. I grew her from like 350 grams. I'm like, it's just, it's really cool. Like I literally helped save your life many times. So it's cool. It's a unique part of the world. I would say it's very boutique. Everything you do really affects the projection of their outcomes. Like literally one thing can change a baby's projection for the rest of their life. So it's you do have to be very diligent. You have to be thoughtful, mindful, understand how the brain and the heart and the lungs are affecting everything, your volume loads, your hemodynamics. If we're going to transfuse, why are we going to do that? Because if we do transfuse, we're potentially going to give the baby a head bleed, which could potentially result in CP. So there's a lot of things, but then if we don't transfuse and we don't get their hemoglobin levels up, so there's so many complex things when you're talking about growing a human being. So
yeah, it's really cool because when I got out of nursing school, I wanted to go to the NICU. So like you telling me all this stuff is like, I'm super interested. Like I'm kind of thinking about like even like switching jobs right now, because yeah, when I graduated, I definitely wanted to do NICU, but there was no NICU jobs available, so I decided to do just a cardiac ICU. I knew I didn't want to do anything neuro related. I hated neuro. I still hate neuro. But like the one thing that really like hits home is like when you mentioned that these babies are so vulnerable coming into this world that it's like you said, the ET tube, it's not inches, not centimeters, it's like literally millimeters.
Yeah. Oh yeah. Yeah. When we pull an ET tube out, it's by like 0.5. Or like by, or when we're, whatever you're doing, everything is like by literally micro of everything is how we measure everything. So yeah,
crazy.
Yeah, it's a really great thing. And it's actually interesting because you and I, we were talking about this prior to coming on, and, the male presence in the NICU world actually it's so nice. I mean, we have some of the best male nurses. I think they bring a really strong element of critical thinking and tenacity and just sort of like honestly humor. Like it's kind of nice to have, like, the male nurses are great because they get down to work, they get down to business, they get your stuff done, and their support system in a different way, and they're just, it kind of brings that element. I love my male nurses, especially in the NICU.
When you say millimeters on the ET tube, do you guys do a chest X-ray for like these little babies, or how do you guys verify placement?
Yeah, so, okay, that's actually kind of funny. Now that I'm in critical care flow, I can understand all these things. Okay, so for ET tube placement, the goal is for most NICUs, obviously not every NICU is like this, is to do one X-ray do an adjustment. And if you need maybe to do another one, but we really try to limit the amount of x-ray exposure we're doing to our babies. And to be honest, I think they changed the settings on the x-rays to kind of like make it a little less exposure.
Radiation.
But yeah, so what we'll do is they come in, do the x-ray, check our placement, and if we need to do another one. However, for OG tubes, NG tubes, all that, no. Mm-mm. You do it with air and listen. We do not check with a chest x-ray. And it's funny because I had a kid just the other day in PICU who does check with x-ray, and it was on a 1-year-old. And I was like, wait, why would you do that? And I didn't realize, like, I couldn't start, like I was like talking to the doctor. It's like, oh yeah, like I dropped the tube, like we're good. And she was like, did you get an x-ray? And I was like, why would I need an x-ray? And then I was like, oh, okay, yeah, different unit, different policies need to do that, so it's interesting.
Yeah, because like working with adults, it's like extra for like everything. Like, you adjusted the like the NG tube, x-ray, and then you adjusted again another x-ray, you adjust the ET tube, x-ray, like he vomits, x-ray. It's literally run these tests like nobody's business sometimes.
Yeah, no, we at least in the NICU where I work primarily, we really try to limit it as much as possible. So yeah.
Yeah, that makes sense. And for NICU, do you guys have any kind of like extra like accreditations or any kind of some places require ACLS? There's like extra PALS for peds.
Yeah. Okay. So the main things you need: BLS, NRP, which is the neonatal resuscitation program. So NRP basically is it's designed to help you come in a delivery and resuscitate a baby who would be down for any reason. So that's everything, and that's not kind of a fundamental issue or a thought in NICUs. Airways, everything. Airways, everything. Typically when your baby is decompensating, usually it's your airway, unless it's a complex cardiac issue, which is a completely separate issue. But NRP is the big one. So a lot of places now, which I really like, are doing actually yearly called CET trainings, where we do practice mock sims with doing NRP and implementing it. So, God forbid your doctor isn't there, how to, properly bag a baby, and, how to work through SOPA and make sure your, airway placement, PEEP, checking all your equipment, making sure everything's good. So NRP is a big one. BLS, the place where I work at 2 different facilities. One NICU requires PALS and the other one does not. The one that does require PALS is because you potentially float to bigger people units, so any like of the pediatric setting, so that would be appropriate for that. And now a lot of NICUs, which I really love, and I'm actually going to be taking it for the first time this year, are requiring stable, which is a newer one, which I happen to think for a lot of our babies in the NICU setting is a lot more appropriate. So it's more geared towards the older neonate who, is decompensating in your unit for whatever reason, and we can't figure out why. So it's like blood sugars, airway, it's like a bigger picture, as opposed to NRP is more specific to, like, I would say more honestly delivery time and to our micro preemies, and to, NRP has a really good place for certain things, but then I think actually stable might be more appropriate for other settings. So yeah.
Okay. So and regarding PEEP, do you guys do like PEEP of 5 for babies, or is that like way too high? 5
is pretty much our standard. We go up to 6, sometimes 7. But PEEP are it's kind of like our live and die by, making sure what they are, especially because with these little ones you can blow their lungs so quickly. Like blowing a pneumo is like, you have to be really careful with these lungs. So that's a big thing for us. Monitoring, understanding your vent settings, understanding certain gestations, why you have your vent settings like that, or with certain diagnosis, why you have your vent settings like that. Cardiac kiddos, really understanding your perfusion mismatch and why you're ventilating this way. And, if we do X, Y, and Z, how is that going to affect the brain development versus growth development? These pressors, how is this going to affect, the carotids, which goes up to the brain, which could cause a brain bleed. Like, there's so many complex things in a level 4, specifically NICU. And I refer to that a lot because that's primarily where I work, but you know, not every NICU's that complex, to be honest. Like some NICUs have far less going on, and they're much more, you know, they'll have level 2, level 3 NICUs will have high risk deliveries, some babies on CPAP and requiring some antibiotics because maybe mom had an infection. You know, you're working on feeds and endurance and weight gain and things like that versus a consult center where, you know, you have several teams consulting on your baby and things like that. So
I'm going to switch the energy of the conversation a little bit right now. So you mentioned that you're level 4 NICU, right? So that's probably trauma, correct?
Trauma, yeah. Mm-hmm.
Okay, so I wanted to talk about death and dying a little bit. So as you know, when it comes to like older patients, death and dying it's still rough. You know, you have the family member crying, the parent, whatever it is, right? The daughters, the siblings, and it's a tough time, right? But you deal with somebody that's just born. You know, it's easier to let go of somebody that lived 70 and 80 and you can say they had a good life. But this person is a few months, right? Not even person, this baby is a few months. Like, how is death and dying in a NICU, and how have you been like coping with it?
Yeah. In my personal career, I've body bagged, I think 6 or 7. It's really, you know, I mean, I remember my first one, like, you know, you never forget that. It's really, really, really tough because you're dealing with a situation where the parents are supposed to be working through the happiest time in their life, and they're supposed to be celebrating. And, you know, oftentimes we have littles who, you know, they're born too early, and, you know, even, you know, we can save up to a point, but maybe they haven't had, you know, an infection which caused X, Y, and Z, or we get congenital anomalies where these babies are, you know, unfortunately, they just chromosomally or genetically aren't able to survive. That's a very real part of our job. And part of that is, you know, extubating and helping and supporting families. It is a balance. I think that, you know, we get in NICU nurses, I think would agree with me on this. Like, you genuinely love what you do and you give so much heart to every single patient. I think that's definitely the hardest moment you deal with as a nurse, for sure. And it is a very real part of it. And I think part of it for me that has been helpful is working in places where I feel supported. I do feel that my fellow nurses, the charge nurses, they just know when these shifts are coming, or, you know, it's a little different if it's a trauma situation and you're coding a patient who versus a baby who you're actually you're extubating, you're choosing this. But regardless, I feel like I've worked in places that have been very supportive. We actually have, you know, bereavement. We have a bereavement sort of protocol, I guess you will, where, you know, we can do handprints and footprints, and, you know, they're really supportive of whatever the family needs at that point. You just, you know, do they want pictures? Do they want to give a bath? There's a whole lot of things that we can do to allow a family to really like grieve in the way that they need to. I have had families who don't want to be there. And I'm the baby, I'm holding the baby. I'm the one doing it as she passes. It's, you know, it's unfortunately a reality that we do deal with. You know, and it's kind of this combination, I think, of this time where we're catching these things early and we're able to save a lot of patients. And then, you know, on the flip side, we're also dealing with, we saved the child for now, but is it going to be feasible long term? So it's interesting, you know, I mean, it's harder when it's really unknown, when parents just really don't know the diagnosis, or the baby just came way too early and there's nothing you could do. But, you know, it's leaning on the people around us as nurses and taking care of yourself. That's a big part of it, you know, and kind of letting yourself feel it, but also, you know, you have to be resilient. There's been shifts where like I had to, you know, take a baby to the morgue and then I was coming back the next night, you know, it's like, that's how it is. And that's in healthcare, I guess, anyway. You know, you were dealing with really heavy things oftentimes and you still need to show up for your job. So
yeah, I remember for like my rotations with like peds and NICU and like mother baby, like the hardest thing for me like to like work with was kids that had abuse. Like one of
Yeah.
like things that I'm always gonna like, I'm never gonna forget this. Like a baby came in for was it shaken baby syndrome, where she had like a severe C-spine. And the crazy thing is like everyone knew what happened, but DCFS wasn't involved yet. That's like the child protective custody that is here in Illinois, DCFS. I'm not sure if it's nationwide.
In our unit,
Mm-hmm.
we see, so most of the shaken babies go to PICU, I would say. And I've actually had a little bit more of that kind of exposure lately. The form of abuse that we would see is from, drug addicted mothers. That does happen. And it's interesting. It's a very weird time because a lot of times, moms will come in, they're loaded, babies come out, we test them, they're positive, and then it sort of sparks that cascade of, okay, CPS, are we getting them involved? Are we doing foster care? At one hospital, I feel like I see it somewhat, but not often. And then my other hospital, I feel like I see it more often. So it's interesting because geographically, I think that's a big factor when you're talking about substance abuse and things like that. But that would be our form of I would say child abuse that we have experienced. We don't get necessarily always the shaken baby. Maybe some NICUs maybe take shaken babies, but usually the PICU takes them.
Yeah. So it's like my hardest part was like allowing, because before child custody came in and did whatever they had to do, like the family was still allowed to like be with their baby, like hold them and whatever. And like everyone knew what happened, and like that's what like killed me inside. It's like this baby is basically has no neural reactions, can't breathe on its own, can't do anything because like the baby was shaken by the family. Like they're the ones that did this to the baby, and like we're still allowing the family to be there to interact with the baby, well knowing that this is the cause of it was the family's doing this damage. And that was the most upsetting thing to me. I came home, I was like holy shit, like how does this even work?
Pediatrics as a whole, I would say that's a big factor, and something that I didn't realize, getting into peds period, that it's a big factor. Abuse. I've had or seen, this was when I was working at U of A, children who would come in at like 6 years old high on weed, and just because parents wanted to shut them up and quiet them down, and that's a very real thing. But we couldn't do anything because the chief is in charge on reservations, so our CPS has no jurisdiction there. So there's a lot of complex things that you're dealing with in the peds world when you are dealing with a very vulnerable patient population. And sometimes I would imagine also being a parent, sometimes it's hard because certain things that come in, we automatically assume abuse. And it's not always the case. Like sometimes they come in and you're like, this is really odd, but then, it most likely isn't that. So it's, there's a lot of very complex things, and kids are actually at a certain age, they'll tell you what happened to a certain degree. But for the shaken babies, it's a really tough one. That's a really tough.
That's also interesting how, I actually noticed it because on a chart, you usually chart interviewed alone, patient interviewed alone. I feel like that doesn't really matter for the elderly, but for situations like that, having a young child, I feel like it's crucial to actually having the family step aside. And I'm sure you have that where, the child is telling you the truth of like what's going on. Yeah. Because I'm starting to see it. Like I had a guy, he was like 92 and his son was just very awkward. And the long story short is he was getting Social Security from him. So he tried to keep him alive while the guy is on a BiPAP mask. And, sometimes in the ICU, we like overexhaust these people. Like they're on their way to heaven and we're just like kind of holding them down with a freaking like a piece of rope while their soul is just drifting away. And like the guy takes off the mask. He's like, let me just die. And you should have just seen the son's face when this all happened. And then we knew that he was technically able to make his own decision because the son was making it, and we let him comfortably pass. But I'm sure, just to kind of wrap things up, we're talking about abuse, right? I'm sure it happens in peds, and it's a lot more, it's sad compared to like the situations we see.
It is sad. Yeah, there's no way around that. It is sad, and it does happen. So I think that is something too for future nurses. I mean, every situation's different, and I do feel like I have felt lucky enough to be on units where I feel supported as a nurse, and you just chain of command, and you let people know, and you chart, and you try and do the best for your patient. In the moment, you try to do the best you can every shift.
So with
Yeah,
like all the,
go ahead.
I was gonna wrap up to like
Mhm.
NP now. So PD, take away with that
Okay.
question.
So yeah, so like we keep touching on this like death and dying. I feel like death and dying is more of a normal occurrence in adult ICUs, which is like a good thing because obviously you don't want more babies dying than elderly. So like I'm more accustomed to dying. I'm more accustomed to letting people go, and I'm more okay with it because a lot of these people are in their 70s, 80s. They live the life, and sometimes it's like a relief, like letting somebody go, like having to like withdraw of care or change their code status because this patient's suffering. But like I can imagine myself being in a NICU, and that would be like one of the hardest things for me to do in a room, just because like it's still like a baby, like this baby could become anybody in the world.
Yeah.
So like with the whole adults, like I'm completely comfortable with death and dying. Like I've been a nurse for a while now, but like the whole NICU thing and like infants and children and babies, that would probably be the hardest thing for me to do in the world.
Yeah, it is. It's definitely I would say the hardest thing, and I do feel like the things that get you through are your coworkers. For me, it's like those are the people that really help you through those tough moments. So yeah, it is. It's kind of a weird time when that you should be at the beginning of your life and be the happiest moment of your life, and it turns into that. It's really tough, but it is part of our job. So yeah.
Yeah,
With
I
all
can see myself being a NICU nurse that's saying, no, we gotta keep doing everything. We gotta keep doing everything. We gotta keep doing everything. And
Yeah.
sometimes you just can't.
Mm-hmm.
with everything that you're mentioning in NICU, I'm actually wondering, so what made you make the leap into becoming a nurse practitioner and leaving the bedside? And are you planning to actually returning to the NICU as an NP, or are you going to take a different route?
Yeah, that's a big question. So I think I hit a pretty big burnout moment, I would say around year 6. This was after, having worked full-time as a NICU nurse and done some traveling, and I just hit a point where I was just feeling, it wasn't necessarily the patient population or like being a NICU nurse. It was just the grind and the intensity of the hospital, and just, feeling, I don't know, I just had hit this really deep burnout moment. And I started realizing, okay, thinking about where do I see myself long term. So I really gravitate to women and women's care and to babies as well. And when you're choosing, I knew that I wanted to take the next step with my education, just because I feel like while I am burned out of the hospital setting and the intensity, I'm not burned out of the responsibility. So for me, the next step is, okay, well, if I'm going to take that, I need to take the next step in my education and go to the clinician route. I've never been interested. I was at one point interested in leadership or going into that way, but I think for me, I'm much more interested in health and prevention and or some sort of that type of care. So I decided to go family route versus NICU or neonatal nurse practitioner. Reason being, with the neonatal nurse practitioner, primarily you will be working in acute settings. You're going to be working in the NICU. And your role is very different, which I just feel like, you're going to be intubating, putting in lines. You're going to be doing much more hands-on, attending the high-risk deliveries, making the tough calls. And I just think for me right now, I would prefer to be on more the clinician side of helping and supporting women, maybe even prevent the pregnancy issues, or being a support system, or becoming more on the pediatric level and being more in touch, I guess, with the community setting. That's just where my heart is drawing a little bit more. So I chose family nurse practitioner. It was after a lot of thinking. I thought NNP, PNP, pediatric nurse practitioner, or even women's health, but I didn't want to niche down too hard in anything. I kind of want to keep it open, and even looking through job searches, to be quite honest, FNPs are there's a lot more opportunity. So I don't quite know exactly where I'm going to be niching down yet. I do know family really interests me. I really love it. I mean, even going into my new unit as a float pool nurse, I'm sort of seeing a lot of the kids that maybe I would even be referring to the hospital. So all these RSV, Pseudomonas, all these kids potentially that I would be maybe seeing in an urgent care, whatever, wherever I want to be. I'm just thinking a little differently, diagnosing, getting down to pathology of like what's going on, understanding a little bit better. I'm fascinated by that. So that's kind of the reason I took the route. I don't know 100% where it's going to land yet. And I kind of like that. I kind of enjoy that. So that's kind of where my reasoning was, like, as to going back for my nurse practitioner. I'm just ready for the next step.
That's actually really good. I like that. And I've been thinking about potentially going more like, further to school. I tried to shadow a CRNA.
Yeah.
As of now, I'm enjoying what I'm doing now and as we're speaking. So we'll see what the future holds, right? So taking your 7 years of hard work, thank you for all that, by the way, and just looking at healthcare as a whole, looking at COVID and just seeing all this shit that's happening, like what's one thing in healthcare that you would change if you can?
Well, I think if there's one thing that COVID has done, it's really opened up our eyes to what healthcare in general, and I think my biggest thing, honestly, is access. Like, I wish access for whatever reason is so much easier. I mean, Lord knows, you guys, we're even nurses, and I bet you don't even know how to access X, Y, and Z if you needed to. Like, it's frustrating. Like, we switched over insurances, and I'm like, why is it so complicated? I basically want to become, I'm hoping, a practitioner that makes it easy, right? Explains things, because half the time I go in, if I'm sick, like, I feel like I'm having to navigate it. Why am I having to tell you that I need these labs drawn? Why am I telling you where to go for X, Y, and Z? So I feel like for me with healthcare, it's becoming a little bit more of an innovative person. We're in 2020 right now. It's like, why is this so complicated? I don't know. I hope that things, as far as access and care and, compassion and getting back to caring for people and treating them as humans. And, there's a lot of mistrust in healthcare, to be honest. And I honestly don't blame people oftentimes, because, one person will say something and another person says another. And I think part of the reason why I started my podcast was to be able to platform and to talk about healthcare in general and see all the things that are going on and how people are doing things. And I think people need to understand dynamics. They need to understand, what their what resources are available to them. I'm really passionate about that. And I think it's crazy because there's so many things out there, but people just don't know how to navigate it. And I do think it's really frustrating. And especially right now, I think, we're in a place where I think that the medical community has finally kind of come together, and really, I've seen a lot of people band together with COVID. If there's one good thing that came out of it, I do feel like that's kind of becoming a forefront for us. And, I feel like now more than ever, I just know I'm meant to be a nurse practitioner and to be able to help people in a way that, they don't understand, or comorbidities. Like, there's so many things going on. And I'm just really feeling the draw to that. And I just feel like as a whole, we're going in the right direction. But it's going to take the right people in place to really implement and make some good changes. And I hope that we continue to work in the right way. I love the medical world. I love healthcare. I think there's so many amazing things going on here. And, just making it a little bit more accessible to people and understanding things. And yeah.
Yeah, 100% agree with that. Like, access and like availability is and prevention is giant keys. Because if you go on your state website, like I didn't even know my state had a website until until I was in college, in nursing school, where we actually went on our state website and we actually went to like the healthcare tab and actually saw what the county or the state actually provides. And they provide a whole bunch of things, like different kind of clinics, different kind of testing, different kind of women's health things. And I had no idea about this. There's like so much of it, but what's the use of it if nobody even hears about it? It's kind of like almost pointless.
Yeah, and getting to people where they need to be. Well, that's another reason too. I get this question a lot of like the social media stuff, and I'm like, to me, I feel like having a presence on social media is very important for the healthcare community. I think it's really important because guess what? That's where all of our patients are. And that's where everyone's at, is on platforms. So I think, yes, there's a tasteful way to do it and a right way to do it. But I think having a presence and being able to show people like, hey, like this is my lifestyle. This is how I'm eating. This is what we're making. Like, I love being able to do that because as a nurse practitioner, when you come into my office, I'm actually doing those things. And not only that, I want to show you, or this is my journey as a nurse. Like, this is how I did it. These were my failures. Like, we're all people. And, can we get down to the level of like letting people, having people understand it? And don't get me wrong, social media is not for everybody, but I do think having a big presence or having, relatable talk for people is really important. Here's the reality too, is COVID has really brought to presence the fact that it's gotten us back to medicine where we don't know everything. We don't know this. We're fighting this and we still don't have all the answers, but guess what? We're going to do the best we can to figure it out. And some of the best, most wonderful minds are trying to figure this out. We have people in overdrive trying to fight this thing. And I'm like, well, that's what medicine is. Like, when you get really down to it, when you get down to healthcare and medicine, it's like, we don't have the answers for everything. I mean, things that we say that we're doing right now, 20 years from now, they're going to be different. That's a fact. Like, we're going to be doing things right now that will be completely out the door 20 years from now. But in this moment, this is what we know, and this is the best we're going to do. And, we're going to try and get you to the most foundation of health and make you healthy and give you the resources that you need in your own personal health. You know what I mean? That's
exactly like the one stigma with like hospitals and medicine and like healthcare is you go into the hospital and you expect to get like cured. Like we have cures for things. We really don't have a cure for a lot of things out there. It just, we have different treatment modalities and ways we treat certain infections, diseases. We don't cure you. We just treat them and hopefully your body could fight it off itself, because there isn't like, you can't put a vaccine for everything. We don't have a special drug that's gonna, cure your illness. It's like you said, it's just like a trial by error kind of thing. We kind of try it out. If it works, great. We'll keep doing it until next better thing comes.
Even if you give it to someone and they're cured of it, the next person comes in won't be. That's just the reality. Everyone's different. Everyone's microbiome is different. Everybody's reaction to things is different. Everybody's, some people are healthier than others. It's all, and kind of, I get people, do kind of like what you're saying. They want the pill is what you go to, right? It's like in your head, you're like, give me something because I have something and I want you to fix it. And sometimes it's more than that, right? It's like there's a lot more complexities and getting people to really understand that, and kind of, becoming more, I think, in the nurse practitioner realm and PA realm, I think it's a little bit on us to tell people, like, you got to put in the work. Like, if you want to get better and you want to do this, like, you're sick right now, but like, let's look at the big picture and let's get you healthier in a better way. And that's kind of where I'm hoping to venture.
That's good, because like, you're young. Like, one of the issues I see with like healthcare or government or like state-run programs is a lot of people that are running these programs or running these facilities, they're older. They're like really old, and that's not necessarily a bad thing, but there comes a point where you got to pass the torch on, because at a certain point, the 70-year-old person is not going to be able to grasp social media or grasp marketing or be able to relate to us. And the passing torch, it's hard. It sucks because we all like control. We like being in our position. It's like me giving away my job to another nurse. Like, I feel like I could do it better. And that's kind of the stigma that everybody has, that I could do it the best. It's not necessarily always a thing. You could do it great. The next person could do it great as well. But the fact that you got to pass that torch, sometime before it kind of gets, unorganized and you're not in mainstream anymore.
Making it relatable. Yeah. I mean, relatable too. It's a big part of it is, being able for your people to really understand, you and us in healthcare and things like that. So I hope that we're going there slowly. And I feel like these kinds of things like podcasts and, social various platforms. And, I think it's important right now.
And hopefully so many great ideas here, guys. Great conversation. Now, hopefully this opens up a can of worms to people where they start taking accountability for themselves. And, you know, we are the most trusted profession. Maybe patients, they'll find platforms like this and they'll listen to us more, because you know how we say that we want a pill for everything and we like a quick fix. Well, maybe doctors are starting to see that trend, and maybe they're just burnt out by patients and they stop having, you know, there's compassion fatigue. Maybe they have compassion fatigue where they don't want to tell patients, hey, maybe you should diet for diabetes. And instead they're just like, here's the damn pill because I know you're not going to do the work. So you never know, you know, I'm just trying to be the devil's advocate and thinking maybe doctors are burnt out themselves with what's going on.
Yeah, I would agree. I do think there's a lot of burnt out fields, I think, just in some part of the medical field. I would agree with that. I mean, I had one doctor, this was kind of maybe one of my sparking moments. I was working on the floors, and I'm not taking care of this particular patient. I was in the room with another one, and the doctor was discharging a female nurse, I think or female patient, 15 years old. And I think she had like PCOS or some sort of ovarian issue. Mind you, she was laying in bed eating McDonald's and sucking down a Gatorade, okay? And he comes in, and the medication he prescribed was a birth control. And the mom had never given or dealt with birth control ever. Mind you, I'm a female. I was on birth control for many, many years. So the thing, he basically prescribed it to her and said, the only side effect is that she may have some mood swings. And mind you, she's 15 years old, okay? And the mom was like, he literally handed it to her. He was like, okay, good. Like, nice to meet you. Bye. That's literally what the exchange was like. And in my head, I'm like, okay, so you just prescribed a medication that could potentially cause this girl to have not only mood swings, but weight gain. Like, there's so many things. My mind was baffled. I mean, the amount of things that I went through with my own experience with birth control was insane. Not to mention the fact that we're not talking about her health. We're not giving her references to OBGYNs. We're not giving her references. Like, I was just so like baffled by the encounter. And I was like, this is the problem. This is where we're at. Like, this is why I just feel so passionately that we need to get to the root of things and give people accurate information. Like, is this the best solution? Birth control? No, it's not. A better solution would be, let's get down to the fundamental of why it's happening. Why are her hormones off? Let's get her diet adjusted. Let's get her exercising. Let's do all these things. And yes, that is an adjunct, and that's very important. But it can't, that pill isn't your solution. We need to, you know, don't get me wrong. My brother, on my podcast, he came on, we're very open about this in my family. My brother's bipolar, and he needs his medication. Like 100%, my brother needs to take his medication every day. He's sober now. He knows that. We have like a whole great episode on that. But so I'm not saying that I'm not a believer in meds. I'm not a believer in like a fix, in a quick fix. Like, trust me, there are moments when, you know, if someone's in crisis or you're doing that, or you need something, absolutely. We live in the 21st century. That's why modern day medicine is the way it is. But we also need to think about the other fundamental parts of it. So yeah. So that's my tangent. I was not anticipating to go here with you guys.
No, it's perfect, because like you said, like, people come in and expect to take a pill, and like this pill does solve this one issue, but then this pill also comes with certain side effects, and then they take another pill because this medication is making them nauseous. So instead of birth control, now they're getting like 2 pills, and then that pill is causing another reaction. Now they're like on 3 or 5 pills, you know, instead of like hitting the core, where diet, exercise, maybe a change in lifestyle might have solved these issues, or made this illness or disease more bearable, and without the patient be able to live without any kind of extra artificial medication.
Yeah, I mean, I have a great example. My dad's 8 years old this year. I think he weighs like 165. He, up until COVID, working out every 6 days a week. And he eats really healthy, and he still has high blood pressure. So I'm not saying that, like, you know, I mean, for where he's at, very healthy. I'm like, I hope that I am like that when I'm that age. But he still has high blood pressure because that's genetic.
Yeah.
In our family, that's how it goes. So, you know, it's a balance of like, let's talk about the full picture, and, you know, so anyway, it's interesting to see, and I hope that, you know, providers are all feeling this way too. More providers.
Yeah.
I kind of wanted to see what you guys think about whole COVID and wondering if nurses are going to be rewarded finally and we're going to be more respected. But since we're talking about working out and maybe there's nurses that want to get more in shape, you have 7 years of experience. How do you stay fit and healthy as a nurse? Do you have any advice for those or nursing students that are struggling and, want a beach bod or some shit?
Okay, so I'm not nearly as good as I used to be actually right now. I do feel like COVID has done a thing or two. But, okay, so I mean, for me, honestly, working out at this point, I'm 31 years old, and I do it for my mental status more than anything. It's more like a relief. I ride horses. My mom's a horse trainer, so I need to be outdoors. I need to be doing something. I'm also severely I'm so ADD, it's ridiculous. So I like doing things, and I think getting active is part of that. I did do a muscle contest back, I think it was 24 or 25 when I did it. So as far as understanding the body and lifting and things like that and your diet, that particular moment was definitely one where I realized how much your diet affects your body. At that point, I had cut out pretty much everything. I literally ate, it was chicken, some sort of fish, carbs were like rice and oats, and then I ate quite a few eggs and veggies. Veggies was a big thing. I had cut out dairy, most fruits, all powders, no ketchup, mustard, like some mustard. But I got really creative with my cooking, and, you start using things like herbs and lemon acid, and you cut out all of the sodium. And let me tell you, with that, along with drinking nothing but water, your body will, the transformation I had over a couple months was insane. And primarily it was because of diet. Working out wise, I personally love, I haven't been doing it as much, but I love lifting. My brother, and I would say my husband as well, are somewhat of gym buffs. So I'm kind of surrounded by it. I tend to be a little bit more on the HIIT. I love HIIT workouts. So, doing stressful, getting my heart rate up for, let's say, like 5 minutes, and then doing like a minute rest. I'll do like stairs, run some stairs, and then do some squats and lunges. That's more my style. I'm not so much, I know a lot of people really do like classes. I think classes are great for people who love the structure. I'm just more of like a free bird. I like being able to kind of, go on a run and then maybe go do some lifting the next day, or it's definitely a mind release. And I do feel like it's a little hard right now because obviously we're in this situation, but we do a lot of prison workouts at home. So we do a lot of the, sit-ups and push-ups, and doing some running around the neighborhood, that kind of thing. So
yeah, that's cool. Because luckily my buddy, he missed the gym so bad, he built like a rack out of wood. So so it's clutch. We've been working out basically in there, and he's got a bunch of weights. We have like up to 315 pounds of weight. So like we could kind of lift heavy. We could pretty much lift heavy on certain days. So.
Yeah. My husband's actually pretty lucky. He has a buddy that they have been working out together since day one, and they're doing the similar kind of thing. So it's definitely good. I think, the other thing too is I've been listening to a lot of podcasts lately, and I don't remember who it was. Maybe it was Ed Milet show or something, but they had on a guest who basically said something to the effect of, every single day, you need to stress your body out to a point, get your body going, get your heart rate up, stress it out, because it basically triggers your survival mode. It triggers your body's like mitochondria and gets everything going. And if you're basically putting yourself in a situation where it's uncomfortable, right? You're feeling like, I'm uncomfortable right now, but I'm going to push through it. The mortality rate goes up like insane, so we're thinking like, I think athletes, I think people that are pushing themselves and are at their peak, and you just watch them age, and they age so well. And, I'm a big believer in that, getting uncomfortable and doing hard things. And, I like pushing myself. I would say 3 days a week is where I'm at.
Really?
I like how you say like stress and all that, because that's like what, me and Peter have the Whoop band, and it takes in your recovery, your heart rate variability, and then your strain level throughout the day. And it tells
wanting to get that.
What's up?
You're wanting to get one.
You guys should. Peter, throw it a discount code so you get a month free. But basically, like, this tells you, hey, what is the optimal strain you should have? So if you slept 8 hours and you have like 90% recovery, the whoop band will tell you, hey, you could exercise a lot more because you should stress your level out to the optimal level, what it could handle, because it's good for the cardiovascular system.
Yeah, it's great. I mean, I love that kind of stuff. I mean, the whoop, I know my husband's a CrossFitter, so he's all into the whoop. Mm-hmm.
And
yeah,
like
when it's cool because like it tells you like when you put an exercise in, like there's like so much exercise. You can do canoeing, you can do running, like, and it calculates how much strain you took on based on your heart rate variability, and it tells you like you're at like 10.4 strain, 8.6, and like the way you sleep, it tells you how well you slept, how many times you got disturbed. Like Matt said, it tells you how much strain you could take on, and then you can just add your strain during the day because it's like a second by second. You're always wearing it. Like you can shower with it, you can swim with it. It's always on my wrist. Except when it charges, it has like a little box you put over it, and then it just charges on your wrist.
That's something we talk about is your sleep. Sleep's a big one too. People.
And I was always big on like biohacking, like trying to get the most out of my body, and this is kind of like provides that for me in like the physical sense.
Yeah. I love that. Yeah, and I'm a big believer in that. I mean, as far as health, and it doesn't have to be something crazy. I mean, I know a lot of people. One of my good friends also came on our podcast, and she talked about her journey through. I think she lost a total of like 100 and something pounds. I don't know, but she's an emergency transport nurse, and she transformed her life. And but it was small things, you know, it doesn't have to be a big thing. I think that's where people get like so worked up. It's like you get to a point of, you know, you're feeling bad, and you just stop. You just don't want to do anything, or you just feel nervous. And I'm like, well, okay, start small. Go on a walk, you know, go do a couple walk lunges, you know, and the next day, like, go on a 30-minute walk instead of a 15-minute walk. You know, it's just like, it takes little things. And I think it's, you know, it's different. It's a different picture for everyone, what they have accessible to them and things like that. So you make it work.
And I like how you also mentioned that you work out for your mental state, basically. And that's what I really enjoy myself, because I feel like sometimes my mind, I don't know if it's because I'm an empath, I'm running 1,000 miles per hour, and exercise grounds me. That's why when I wake up, and I've been doing this routine, is I'll meditate, I'll stretch, and I'll do like a little workout, and then I'll plan my day. And it just, for some reason, exercise just gets me out of my damn head. And that's what I need so much in my life.
Yeah, I think we all do. I mean, I do. I feel like that's like partly one of the biggest things for me lately, is especially right now. But, you know, I think exercise, that's like the most immediate thing you can do for your body. That and what you put in your body. I'm really passionate about that. It's, you know, that's all on you.
What was your favorite cheat meal?
Okay. Well, burgers. I'm a burger girl. Burger's my favorite thing. Tater tots. I've talked about this a lot. I love bar food. Like, bar food, if I had to pick like a category, it's not like Mexican, Italian. No. If I'm going to talk about cheat meals, we're going to go bar food. Like wing, all of the like appetizer menu, you know, I'm all about that. Like the dips, sliders.
Do you like beer in that case too?
Yes. Let me beer. Actually, you know what else I've been into lately is the kombucha. The spiked kombucha's really good.
Oh, spiked? They put alcohol in it? All right. Well,
new companies coming out that are having like these fabulous, like basically they're like a beer. It's like 6%, you know? Mm-hmm. They're really
all basically like me and Peter's friends group, when I went out and I got a kombucha beer, basically they all like talked mad shit about me. I'm like, okay, guys.
No, they're so good. They're and honestly, they're catching on big time here. And the seltzer, there's a new brand out there called Ashland, and I learned about them on another podcast. But the guy who created it is from my area, and he basically was like, I wanted to create something like a seltzer, like you know, like not the Trulies, but something like that, but like for male, like the male side. And so they created Ashland, and I'm like, I'm here for that. It's like the flavors look good. It's like tangerine, lime, like they've got some good stuff. So yes, I'm definitely here for that. And they're less calories than a beer. So
yeah, I'm a big Guinness guy. I like my stouts, like banner for everything.
I'm surprised because your hair is so light. I'm done. I had to wrap up this show by talking shit about the hair since I made a good comment from the beginning. You know, everything comes around, guys. Karma.
Yeah. I never knew there was a relation between hair color and beer preference, but you know, maybe we can start a survey, research study.
I'm gonna run one. Who's gonna fund it? Tori, got money on it? Alrighty, guys. I think we should wrap this one up because I'm starting to get the laughies and I need some sleep.
Yeah, you're gonna get to bed.
So if you guys want to hear more from Tori, you could check her out at www.tipsfromtori.com. Also check out her podcast, Cellfie Podcast, and her IG handle is at nurse.tori_. We'll see you guys next week.
Thanks for having me, guys.
Thank you, Tori. Enjoy your day.
Bye, guys.